So hi everyone, welcome to this Take 20 Oral Health and Pregnancy. Today's Take 20 will be led by Jessamine Cipollina and Dr. Judith Haber from OHNEP. This Take 20 is to learn about the connection between pregnancy and oral health, as well as the strategies for assessment and management of oral health issues among pregnant persons. Before they start, I would like to address a few housekeeping items. This presentation is being recorded and will later be posted on Open's online community at communities.openoralhealth.org, which I will add to the chat shortly. If you do not have a login, please request a login to gain access to all of Open's resources, policy alerts, and network-wide updates. Lastly, we please ask that you complete a post Take 30 survey, which I will also link in the chat shortly. I currently have you all muted, but if you have any questions throughout the presentation, please pop them into the chat and we will have time for Q&A at the end. And now I will turn it over to Dr. Haber.
Hi, everybody. I hope you're having a nice summer day as we are in New York and Connecticut, where Jessamine and I are located. As you can see, for those of you who are not familiar with us, the OHNEP program is located at NYU College of Nursing. And today we're going to talk about Teeth for Two, oral health and pregnancy, because it is not a conversation about one, but a conversation about mother and baby. Next slide, Jessamine. For those of you not familiar with the OHNEP program, the Oral Health Nursing Education and Practice Program, the aim of our program is to integrate oral health in undergraduate and graduate nursing programs through faculty development, preceptor development, curriculum integration, and also for establishment of best practices in clinical settings. And that means in maternity and well-child settings and well-woman settings as well. So we have an abundance of resources related to oral health and pregnancy on our website, ranging from case studies to toolkits, to articles, PowerPoint presentations, all there for your use. The other item that our website features is important reports, as we'll see in a minute, that pertain to oral health and pregnancy. But remember, OHNEP leads the way in terms of integrating oral health and overall health, especially for today, related to pregnancy and those who are bearing a firstborn or a subsequent child. Next slide, Jessamine. There's quite a strong evidence base that has been documented in the literature. Here are some very important reports and articles that have been published in the last 10 years or less. Many of these are very recent articles, like Oral Health in America, Advances and Challenges, and Improving Oral Health During Pregnancy, a call to action that our OHNEP team, along with the CIPCO team out of Harvard and UMass Medical, recently authored in the Journal of Midwifery and Women's Health. But there is a very strong evidence base about the links between oral health and pregnancy outcomes, preterm labor, low birth weight in babies, and overall condition of the pregnant woman's oral health. And she, as the gatekeeper of her family's health, is really in a prime position to promote the infant's oral health from day one, as we will discuss. So these are all important reports, and the consensus document out of the Georgetown Center is another seminal report for you to refer to and guide. And I just want to mention the American Public Health Association, Integrating Oral Health into Primary Care, the resource guide, is another extremely important document for you to access. Next slide, please. So oral health is not important just in pregnancy, but it's important across the lifespan. As you can see from this visual display, the pregnant parent needs to become an oral health champion if that is not already the case. Once the baby is born, oral health can be promoted during well child visits. Think of the fact that a child has 12 to 13 well child visits by age 3, whereas the chance of a child having a dental home established by age 3 is no more than 10%. So beginning at birth, as I alluded to a minute ago, oral health is really important. In toddlerhood, that is the best time to make sure that the dental home is established and that regular dental checkups complement the oral hygiene practices that the parent or parents are going to be champions of at home. And certainly following oral health across the lifespan, oral health care during childhood in school settings is a perfect place, especially where there are access issues for fluoride varnish and sealant application by colleagues on the dental team. And of course, what does this produce? Adulthood with cavity-free mouth and robust oral systemic health, and we're ready to start the pregnancy cycle all over again. Next slide, please. Many people don't know, and especially those in the medical community, that is physicians, nurses, nurse practitioners, PAs, midwives, have not historically known that oral health is one of the leading Healthy People indicators. And that was true in Healthy People 2020, and now again true in Healthy People 2030. And particularly, not only oral conditions are among the leading health indicators, but oral health in pregnancy and childhood is of particular note in Healthy People 2030. And this is all part of a national oral health framework that is being developed by CDC and that hopefully will be published within the next year or so. And it reflects these priorities about oral health. Next slide, please. And so our position is that prevention and management of pregnancy and oral health complications and promoting oral health during pregnancy calls for an interprofessional team. Look at the size of the RN workforce, the NP workforce, the midwifery workforce. We can make a huge difference along with our physician colleagues, our PA colleagues, in collaboration with our dental colleagues. All too often, the mouth has been a forgotten part of overall health, and particularly during pregnancy, where one has a healthy outlook on what the pregnant person is experiencing. But together, we can have make contributions to better outcomes. Next slide. And to provide whole person care, it is often the case, believe it or not, that dentistry is left off this whole person care wheel. And dental hygiene is left off also, forgotten part of whole person care, person-centered care. But we have revised this to make sure that dentistry and dental hygiene are included along with other newer frontline health workers like community health workers, CHWs, who are trusted members of the community and often the best messenger, best oral health messenger you can have on your team. Next slide, please. because the social determinants of health we have learned during the COVID pandemic are the overriders contributing to oral health and overall health disparities. And we've seen how communities of color, communities who are most impacted by the social determinants of health, experience a disproportionate share of poor health outcomes, and whether they are comorbidities or mortality, increased mortality, it is definitely a feature. So we need to be cognizant of the social determinants when we are thinking about delivering effective whole person care. Next slide, please. So we recommend that the oral health delivery framework developed by Qualis, and this is available online on our OHNEP website, think about a framework that integrates oral health with overall health. And this is useful on the dental side as well as on the medical side. To think about for medical providers, nurse practitioners, physicians, PAs, et cetera, think about oral health when you collect a health history. On the other side of the fence, think about general health related to pregnancy if you are a dental provider. We ask all of our medical colleagues to look or conduct a HENOT exam, so you cannot forget about oral health and looking in the mouth and examining it, assessing it when you're doing a health physical exam, deciding on the most appropriate response, the level of risk, and what the management plan should consist of. In terms of pregnancy, the most relevant actions to take are health promotion, disease prevention, oral hygiene coaching for the pregnant person and for the about to be born child, whether it's in the next months, weeks, or days, all important, and then during postpartum as well. And then to make sure whether the interventions are documentable in the electronic health record, either on the dental side or the medical side. Oral health literacy about the best practices in oral hygiene are probably one of the most important actions and forms of coaching that one can do. Next slide, please. And so here's the HENOT article, putting the mouth back in the head, HEENT to HENOT. We recommend not forgetting about oral health, whether it's during pregnancy or any other phase of the life cycle. Next slide, please. And so Jessamine, please take over and talk about the oral systemic health connection during pregnancy.
Thank you, Dr. Haber. So as she mentioned, oral health doesn't just start child, it starts at pregnancy. And so during pregnancy is the ideal time to begin these primary prevention strategies to prevent oral health problems during pregnancy and beyond. Poor oral health during pregnancy is associated with various negative outcomes related to birth, so low birth weight, premature birth, and early childhood caries for the child after it's born. And these are associations among with other similar health problems. These things are already widely documented and continue to be researched. But despite all of this information that we have about oral health and the importance of oral health during pregnancy, access to dental care for pregnant persons is limited, and it continues to be a central feature as to poor oral health during pregnancy for many people. So we know that during pregnancy, there are a lot of physiological changes that occur in the body. These can affect the oral health directly of the parent as well as of the child, the unborn child. The oral cavity in particular is susceptible to a lot of hormonal changes that occur, and these increase the likelihood of oral health problems. And we can see that, despite knowing that oral health and pregnancy are connected, over half of pregnant people reported not visiting a dentist during their pregnancy. 60% didn't have their teeth professionally cleaned, and rates of cavities, periodontal disease are pretty high among pregnant people as well. And despite all this, even when they do have an oral problem, when you feel like your teeth are sore, there's a lot of swelling, bleeding of the gums, only about half of pregnant people will seek out dental treatment. And this is due to social determinants of health that we had mentioned. Maybe it could be due to lack of access or lack of transportation to the dental office. Could also be due to lack of insurance and the high cost of dental care during pregnancy, or just general misinformation about the safety of dental care during pregnancy, which we'll discuss. So the simple version is that bacteria from the mouth during pregnancy, the bacteria can be transmitted into the bloodstream and consequently reach your unborn child. The oral cavity is susceptible to these hormonal changes, and any infection or inflammation in the mouth doesn't stay in the mouth. And again, looking at these health problems that have been found to be associated with oral health: preterm labor, preterm birth, and poor glycemic control during and after pregnancy for the pregnant parent. And these are, again, well documented and continue to be widely researched as we look at the connections between oral health and pregnancy and why oral health care is so important. The key messages for providers and for their pregnant patients is that good oral hygiene during prenatal period, during pregnancy, and regular dental checkups can reduce the risk of these health problems for the parent and child. It's also important for providers to communicate that dental procedures during pregnancy are safe. Dental x-rays, cleanings, most medications during pregnancies are safe, and there's no existing research that shows any negative effects of these things. And as a result, the myth that you have to lose a tooth for every pregnancy is untrue. You don't have to lose a tooth for every pregnancy. You can have healthy teeth and mouth and gums and have a safe pregnancy. So what can providers communicate to their patients in regards to taking care of their oral health for themselves and for their future children? The key aspects that we can take away are: in protecting the baby's health, parents need to implement positive oral health practices. This includes their own oral hygiene and the oral hygiene of the other parent and other family members. A nutritious diet is essential for pregnancy as a whole, particularly in the mouth. We want to, in the interest of keeping the mouth healthy, we want to limit sugary foods and beverages and stay hydrated with water between meals, avoiding juice and soda. These have a lot of sugar that can stay and stick around in the mouth and cause tooth decay. Also, again, reiterating the importance of getting regular dental checkups during pregnancy. And then once baby is born, there aren't any teeth there, but there are gums that will eventually have teeth. So wiping your newborn's gums and teeth with a damp washcloth or xylitol wipes to protect them. And then once teeth start to emerge and toothbrushing begins, brushing twice a day with fluoride toothpaste. The rule that we promote is that for the amount of toothpaste that you use, a smear when teeth start to appear. And by age 3, the toothpaste should be about the size of a pea on the toothbrush. So how can an interprofessional collaborative health team make a difference? All dental and medical professionals have an opportunity to collaborate with one another about educating their patients, as well as educators that are closely connected with students, and educating other healthcare providers about the importance of good oral care and improving oral and overall health outcomes during pregnancy. We have to remember that the mouth is the gateway to the rest of the body, and during pregnancy, the oral health of the parent also affects the oral and overall health of their unborn child. Health teams and offices can also establish an inclusive clinical environment with regards to the social determinants of health that we had talked about a little earlier. This is to create a safe, inclusive space for pregnant persons of all backgrounds and ensure that staff are competent in providing affirming care for all identities. Again, with social determinants of health, we know that dental disease is concentrated among populations with low socioeconomic status, and dental care isn't publicly funded or covered by public insurance. So many people, pregnant or otherwise, have to make a difficult decision regarding their finances when accessing dental care. So resources and just a general understanding should be of dental care costs and accessing dental care. These should be available in all primary care settings with all health professionals that are involved in the care of the pregnant patient. Providers can, again, recommend dental care during pregnancy, talk about the basics of oral hygiene and the importance of maintaining that during pregnancy, and making sure that any myths about the safety of taking care of teeth, dental care, oral hygiene, all those myths are dispelled, and providing ongoing support. And a big piece of this is going back to the HENOT exam, including the oral health and the overall examination of the head, and the throat. So this is a big piece in calling on all of our oral health champions, that is youth and network, and other health professionals in dental and medical fields to continue to integrate oral health competencies and think about how oral health affects us both during pregnancy and beyond, integrating oral health into education and practice, and hopefully the larger effect of improving the oral health status of pregnant persons. Just being able to provide oral care, provide support for dental care, and making sure that the parents are the oral health champions of their families during pregnancy and beyond. So this is a really great resource, and I show this chart as an example of resources that health providers and their pregnant patients can refer to. This is a pretty simple and accessible handout that outlines different pharmaceuticals and their effects during pregnancy, what's safe to use, what's not safe to use, what you should consult a doctor about, what you should never use. So it's handouts like this that are easy to read, that are available online for free. This in particular is from the National Maternal and Child Oral Health Resource Center at Georgetown. The center is a really great resource for all things pregnancy related, for taking care of oral health, pregnancy, and beyond. We recently released our new undergraduate toolkit. We updated the articles, we included new activities for students to do. So this is a great way for faculty and instructors to integrate oral health competencies into curriculum for undergraduate nursing and other health professions. Pregnancy is included in this. We also talk a lot about, again, the social determinants of health, and integrate and making sure that the message is clear that oral health is central to health status at any state, at any age. We also have our graduate interprofessional oral health toolkits. These are for nurse practitioner programs in a variety of settings. And Smiles for Life. If you're not aware of Smiles for Life, you are now. Smiles for Life, oralhealth.org, .com. They have several modules that review how oral health is integrated across the lifespan and in a variety of different conditions. And as always, we are big proponents of interprofessional care across the lifespan for all conditions. And it is really important that dental and medical professionals communicate and collaborate with one another as a means of bringing oral health into the rest of the body. And that is it from me. I'm gonna stop sharing. And we have a few minutes for questions, comments. I'm looking in the chat. What is the best way for this info to get traction among medical health providers? Why the resistance to providing basic information? Dr. Haber, any thoughts on that?
Well, this is a topic of great interest, and it's a recurring topic. And the answer, and this is a very pragmatic answer, is that unless oral health is incentivized as a part of whole person care, that begins when the workflow begins at the front desk and until the time the family leaves the office, the well child office, let's say, there need to be incentives to integrate oral health. We were just discussing this at a national summit that I attended last week. And when you think that, and I don't know when this started, maybe 20 years ago, 15 years ago, the fluoride varnish and idea of integrating oral health into well child care, which preceded pregnancy care, we went from about 1% to now about 20% of well child settings integrating oral health. That is a big change, even though it feels like it's way far from enough. So I think as we see value-based payment changes, models being instituted, oral health will be one of the quality indicators that will be required, and then we will not encounter so much resistance because it will be a must do. So I think that's one thing. I think the other thing that we can do to be champions and to advance our quest to be champions during pregnancy and immediately following birth, when there are infants, newborns, infants, toddlers, et cetera, is to think of non-traditional places where healthcare is delivered. WIC, home visitor programs like Nurse Family Partnership, Healthy Families America, and the like. Head Start centers are all natural settings where we can form collaborative relationships with dental partners who are in the neighborhood, so to speak, and with whom we can collaborate to establish dental homes and teach about and coach about the importance of oral hygiene during pregnancy and during child care.
Thanks. And another piece that I would like to address, it is nearing the end of Pride Month. The Open Network and other organizations, including OHNEP, have had a lot of time to reflect on how do we make oral health and other spaces in primary care and acute care settings inclusive for all LGBT plus identities. And within the realm of pregnancy, the pregnancy historically and traditionally, so to speak, a lot of information, a lot of what we see about pregnancy in the media and otherwise is geared towards women, as it should be. Women are, the ones that are known for being pregnant. However, there is a variety of identities outside of just she, her, that can be pregnant. And so we, in the literature, in our research, and in presentations like this, there is a push within this realm to shift from use of things like pregnant woman and keeping it in the woman's world and moving it to a more equal standing of pregnant persons. This isn't a way of taking pregnancy away from women. That's not the intent at all, but just making it clear that saying pregnant persons, making it more open to different gender identities, those who may not identify as she, her, making sure that they feel included in these spaces and that they're able to feel comfortable in these settings when they're seeking out care during pregnancy. Let's see.
I have one thing, one hopeful thing to add, that there have been, and like the Georgetown Center, I don't know if Katie Battani or Katrina Holt are on the webinar, and I just saw Katie last week, but ACOG is, and that's the OBGYNs, is now evidently paying much more attention to oral health during pregnancy and is becoming a more visible champion of that, where it has largely been the American College of Nurse Midwives that has integrated oral health into its midwifery core competencies and now includes it in their required textbooks and on their national exams for preparing midwives. So there is a lot of progress that has been made in overcoming resistance among the non-dental community, but it's just as important for the dental team to dispel any myths that exist about the wisdom of having oral care, dental care during pregnancy. And that includes dispelling myths like X-ray, having your teeth X-rayed will harm your baby. That is a myth. So the dental community can not only play a part in promoting oral health literacy, improving access, but in coaching and dispelling oral health myths about the importance of dental care during pregnancy.
Great. Let me see. And then a couple thoughts about fluoride. So is there any advice for, there's a bit of a discussion in the chat about fluoride resistant patients, especially with young children. We know that fluoride varnish is a great tool for those resistors, which yes, someone commented. Fluoride varnish is great. It's topical. It's not swallowed. It's safe for mother and children. For yes, Dr. Keller, thanks for
Good.
Yes.
And the other thing is, you know, many parents think they're doing their baby a favor by giving them Poland Spring bottled water, which doesn't have fluoride in it, whereas their community water supply does. So they are really putting their baby or young child at a disadvantage by thinking they're doing a good thing and offering them bottled water, which costs money and doesn't do the trick. It's actually harmful to the baby.
Right. Let's see. Can our public health departments help with promotion? That being promotion of oral health integration? Yes, they absolutely can. It's a matter of, I guess, if they will and how they might. I guess public health departments, maybe at this local and state level, and I don't know exactly, maybe Dr. Haber knows like what their abilities might be.
Just as one example, the New York City Department of Health was the vehicle through which we first got connected to the Nurse Family Partnership Nurse Home Visitor Program. And we did a whole interprofessional presentation on integrating oral health during pregnancy. And that led to, and that was through the health department. They now have 4 oral health assessment questions on all of the elementary school intake forms. So it is a ripple effect, and they can really contribute to promoting oral health. And the other thing I will mention, and this is not necessarily, although it could be preschool now that preschool is getting pretty mandated. Oh God, I forgot what I was going to say. Oh, I know. Schools are often, particularly in underprivileged communities, the only oral health resource a child and family has, so that the health department is instrumental in promoting school-based health, and oral health is often a component to that, and the only oral health access that the family has for their children. I think we're out of time. Valerie?
Thank you so much, Dr. Haber, and thank you, Jessamine. We really appreciate your time, and thank you so much for doing these great webinars